Greetings to everyone, and thank you for attending our very important and unique panel on opioids, substance abuse disorders, and the realities that they are a threat to human rights. Women are using drugs more, and we're going to focus especially on the gender, on the female issues of drugs. Although 1 in 3 people who use drugs are women, women constitute only 1 in 5 people who get treatment. And we'll talk about that. Women are also disproportionately affected by criminalization and incarceration, with 35% of women in prison worldwide, with the criminal justice system in relation to drugs. They're complex, often linked to other factors such as poverty and coercion. Many relate systemic gender inequality in society. I visited a number of women's prisons, and we do have one here in Minnesota. But the reason that there is an increase in women and girls in prison is because they are the mules. They are often the person who carries the drug, and the man at the cash register is not seen. So today we're going to talk about serious, accurate issues regarding substance abuses and opioids. And I'm going to hold up for just a moment several of the recent articles. I don't think people are really paying as much attention to the problem of drugs in the Western world and all over the world. Can we show this on a bigger screen here? Let's see. Can you show the bigger screen, Sarah, on this one?
Hold it still.
Thank you. All right. Okay. This is Mexican Sinaloa cartels cut off fentanyl. The next one, these are all recent. Addiction help eludes many. In a survey, they found that. And U.S. pressing China to stop flow of fentanyl chemicals. And the last, because you will take over. Millions abuse multiple drugs, complicating addiction crisis. So I'll start by turning it over to Dr. Lori Post, who will make some other introductions. We worked together over many years, and she is at Northwestern University. Lori.
Great, thank you so much. So today we're going to talk about opioids and other drugs, and especially the drug overdose crisis. So I just wanted to preface this that we think about it, at a global level. And in America, we usually study as an American issue, but we really can't understand what's going on in America without thinking about the global system. But trying to understand where's the supply and demand coming from, that, access to data is very difficult, not collected, not accurate. Testing is not very accurate as well too in many places. And so but we can't really understand what's going on in America without understanding the larger picture. So, and I'm working on a project where we're trying to piece some of that together, in particular with Latin America. But again, a lot of politics that are involved with that prevent people from reporting, or if the data are reported, they're not for public consumption too. So I thought it would be really good for us to get started and just have an overview about what's going on in America. I'm going to Dan Ciccarone is going to talk about some trends, substances, supply, demand within the U.S. I'm going to talk a little bit about Department of Justice funded center. Marianne Mason is going to talk about specifically barriers for women, and Jay Unick is going to talk about treatment options in the community.
And Lori, I see that Alexander Herman is a participant now. Alex, if you will share your screen or unmute yourself when you're ready to speak, then we will enjoy your perspective on this serious subject. Okay, Lori. Mm-hmm.
Okay, so let's start off with Dr. Ciccarone. Dan is a professor of family and community medicine. He is boarded in addiction medicine. His research is centered on the contextual issues of treatment and prevention of HIV, AIDS, and related diseases in socially marginalized populations. His long-term objective is to combine ethnographic and epidemiological research to explore the intricate socio-behavioral medical issues of medication adherence, access to care, and risk-taking behaviors, particularly related to drug use and drug users. His recent research is exploring the different medical consequences of use of various sources and forms of heroin. The U.S. has recently entered a new heroin epidemic, this time fueled by the recent opioid pill epidemic. His team explores economic, anthropological, historical, clinical, and public health dimensions of this crisis. I turn it over to you, Dr. Ciccarone.
Thank you, Lori. And it's a real pleasure, it's a real privilege to be here today. Thank you for the invitation. Give me a second while I get my slides up. Put that into presenter mode and then full screen. Lori, does everything look okay?
It does. It looks great. Thank you.
Thank you. Except it's okay. So I'm going to talk about the epidemiology of this 20-year phenomena that we're calling some people have called it an epidemic, some people have called it a crisis, but these 4 waves of opioid overdose-related deaths that have happened over the last 20 years. And I'm titling it Beyond the Fourth Wave because it's starting to get messy now as fentanyl is being combined with other drugs. Here are my declarations, possible conflict of interest. I'm on the scientific advisory board for Solero Systems. We're working on a medical device to treat overdose. I work on the side of the plaintiffs in large litigations against opioid manufacturers and distributors. And I'm also the voluntary medical director for Remedy Alliance. We are the nation's largest buyers club of the antidote naloxone, which is used to treat opioid overdose. Distributing 1.5 to 2 million doses of naloxone per year in a low-cost, nonprofit way. Here are the 4 waves. Wave 1 are deaths due to opioid pills. This has been going on for almost 20 years, over 20 years now. We had a little bit of curtailment in the after 2011. But unfortunately, that begat a heroin wave, the likes of which this country has never seen. Heroin use went up, the size of the population of heroin users went up tremendously, and deaths due to heroin went up. Now, we thought that was bad enough, but then the heroin became adulterated or contaminated with fentanyl as of around 2014 in the eastern United States, and then deaths due to fentanyl analogs, and other synthetic opioids have skyrocketed. We have not seen the top of this curve yet. Unfortunately, there's also a 4th wave, and the 4th wave are the deaths due to stimulants such as cocaine and methamphetamine, often used in combination with the synthetic opioids such as fentanyl. I'll go through the waves just one at a time. The first one is well known, is that we had too many pills. All right, too much manufacturing, too much distribution, too much prescribing, too much consumption of opioid pills. We see here, for example, in 2011, on the graph on the left, 2011, there were 219 million prescriptions for opioids. That would be billions of pills in 1 year in the United States. And then on the right, we have a curve of overdose hospitalizations produced by Dr. Unick, who's on this panel. And it's uncanny, the correlation parallel between the rise in opioid prescriptions and the rise in opioid overdose hospitalizations, and then the decline in them as well. So we actually thought as of 2012, maybe there was some good news out here that overdoses were going to come down. Unfortunately, as already stated, we begat the nation's historically largest heroin use curve. 2.3 possible heroin users based on a 2016 estimate, which is a 3 to 4-fold increase from a decade prior. This historic cohort came about as people who were dependent on opioid pills lost their supply. The street became, they became rarer on the street, they became more expensive, whereas heroin remained ubiquitous and cheap. And so we documented this in a couple of papers showing that people were transitioning from pills to heroin. Those papers didn't begin to address, didn't begin to understand the size of the cohort that was being developed. And then fentanyl came in. Fentanyl is a very powerful drug. It's a very, what we call lipophilic drug, which means it goes into the brain easily and therefore has very strong effects on the brain. It's integrated into the heroin supply. This is not a legitimate or pharmaceutical diverted supply. It's a clandestinely produced and trafficked supply. And as I already mentioned, is super potent, 25 to 40 times as potent as heroin by weight. Now, the fourth wave means a couple of things, but since I'm the person who has coined the terms, the triple wave and the fourth wave, I get to define them. To me, it means the Western expansion of fentanyl into places like California. We see this curve on the right there. Unfortunately, the dates have cut off, but we see a dramatic increase in opioid-related deaths after about 2019. And what's driving that is the orange curve underneath, which are fentanyl-related deaths. So fentanyl hit the eastern part of the United States around 2014, here on the West Coast, more like 2019. So a little late to the party, but unfortunately becoming quite a problem out here. But it also, the fourth wave also means this co-use phenomenon of stimulants and fentanyl. I'm going to get into that a little more in a minute. So bottom line is the synthetic problem, the overdoses due to synthetics are no longer a regional problem affecting the industrial Midwest over to the Northeast down to the Mid-Atlantic. We now see them as of 2021 moving into the South, Texas and the Southwest, as well as the Western states. 2021 is the last data that I could get a full national map of, but there's no indication as of 2023 that this has gotten anything but worse. We've had a tripling of deaths attributed to cocaine over the last 20 years and an 18-fold increase in deaths driven by methamphetamine over the last 20 years. And a lot of this is co-use of these stimulants with fentanyls. Here's some data from the CDC shooters database. It's 24 states, of course, the United States. So not quite a national sample, but heading toward a national sample. And they say that 33% of all overdose deaths, opioid and non-opioid, are due to the combination of stimulants plus powerful opioids, such as fentanyl. 80% of fentanyl involved. Of those, 80%, 2/3 are cocaine and fentanyl, 1/3 is methamphetamine and fentanyl. But the co-use of these two is driving it. There's also some concern that this contamination of the stimulant supply with the fentanyls, it's a known phenomenon, but the data that we have shows that it's a minor to moderate contributor. The bigger contributor is co-use, people choosing to put these two together. The speedball combination of cocaine and heroin is traditional. It's been going on for multiple generations now. It makes sense, it's well-liked. The goofball, which is a combination of heroin plus methamphetamine, people are often calling it a speedball too, just to confuse things a bit. But this combination was historically very unusual. The fact that it's happening now is really interesting, right? Fentanyl is finally strong enough as an opioid to meet the methamphetamine, which sort of push all the other drugs out of the way. And so that's why people didn't use them. It was physiologically challenging to use methamphetamine with another drug. But now it's still a little physiologically challenging, but it's growing in popularity.
Hello?
So just summarizing what's really a lot of data, given the short time constraint here. Co-use is rising. This is what's driving the fourth wave, stimulants plus fentanyls. The fentanyl is strong enough to go mano a mano with the methamphetamine. There's a wide range of combinations, rationales, and timing of the two drugs. Robust supply, meaning that it's cheap and available, is driving this. But also we have to think of adaptive responses, that people are actually trying to reduce their fentanyl exposure by substituting the methamphetamine. And that's might be helpful because we have to remember that fentanyl is the deadlier element here. And our clinical responses, our public policy responses need to focus on the more potent drug here, and that is fentanyl. But moving beyond the fourth wave, there's a couple of trends I want to talk about. I want to talk about xylazine briefly, counterfeit pills, and smoking. Xylazine is a growing phenomenon, a growing problem. The first graph to come up shows rises in deaths due to xylazine. This is not a human pharmaceutical. It comes from animal sources. It's a powerful sedative. And so now you're combining one powerful sedative, that's this alpha-2 agonist, xylazine, with another powerful sedative, that is the opiate, the fentanyl. And so we're concerned about increases in overdose. It hasn't been proven yet necessarily that it's adding, but it's likely to be adding to the overdose phenomenon. The reasons why people might be using this, well, one, it's a major adulterant in supply right now, and that is 97% of the xylazine comes along with fentanyl. So it's an adulterant of the fentanyl supply. But these alpha-2 agonists do potentiate overdose. They do reduce withdrawal side effects of coming off of opiates. And so there may be some psychological or physiological rationale in why they're being introduced now. Unfortunately, and anyone who's sensitive to strong images should close their eyes for a second. Oh, I'm sorry, I took the photo out. Unfortunately, they're also causing a tremendous skin breakdown, ulcers, huge, challenging to treat wounds that people are getting. And then the bottom graph that's just come up now just shows the geographic spread of xylazine. It's mostly in the east of the Mississippi River at this point, but there's anecdotes that it's spreading westward. Fentanyl-containing pills are becoming a big problem. We don't make a legitimate fentanyl pill. So if we find a fentanyl-containing pill, it is a counterfeit pill. This graph shows that of all fentanyl seizures, this is a nationwide seizure sample, there's been a doubling in the proportion that comes in pill form over powder form. The reason why this is important is that the demographic changes, right? So pills may be more consumed by women, maybe more consumed by youth, maybe more consumed by people who are, quote, recreational, end quote, users, as opposed to a daily user. And that, of course, exposure to fentanyl among those folks can be exceedingly dangerous. The graph on the right, it just shows the sheer numbers, 2.5 million seizures of these pills in 1 quarter. So I'll let your imagination go with what that means in terms of the actual supply. Smoking fentanyl is on the rise, particularly in the Western states. It's easy to do. It has high bioavailability. People are liking it. I think this innovation is hard to suppress, so my prediction is that this goes nationwide. And it might have strong implications. Hepatitis C and HIV rates should go down. Overdose, I don't know. Might go down, might go up. So the devil's in the details. We need more data. Bottom line is this 20-year crisis is an impressive one, a fearsome one. It's one that requires a comprehensive solution. We need all hands on deck. We need supply reduction and demand reduction and harm reduction. By demand reduction, I mean treatment. We know we have medications highly evidence-based that work for treating opiate use disorder. But one of the things we focus less on is the fact that drugs fall into the cracks in society. And so we need to think about the disparities, the inequities, the ways in which society foments problematic drug use and work toward primary prevention. We also need great expansion given the size of this cohort and harm reduction technologies. We know that sterile syringes reduce hepatitis C and HIV. This was UN endorsed. We know that naloxone as an antidote is UN endorsed, but we need tremendous expansion of these. And this is my last slide. I'll end just briefly at some of the human rights challenges as I see them. This cohort is impressive, right? It's hard to wrap our heads around what it's going to mean to treat 1.5 million new heroin users in terms of treatment needs and prevention needs. The existing inequities, such as by race, ethnicity, and gender, occur across harm reduction as prevention modalities and treatment access, right? And they're only being compounded by the size of the cohort, the inequities, that is. And the frustrations in this era where rising deaths are happening while we're trying to address them is now leading to counterproductive calls for more arrests, more incarceration, taking away benefits, et cetera, as opposed to this all hands on deck approach that says we have 1.5 million new heroin users. How are we going to treat them all? With that, I'll end, and thank you all for your kind attention.
Great, thank you, Dan. Okay, I'm going to talk a little bit about a funded or new, recently funded project. I'm going to share my screen. Oh, is that working okay? Okay, all right, so anyways, just to introduce myself, my name is Lori Post, and I am a professor of emergency medicine at Michigan State University. I am a demographer, and I also work in epidemiology. Right now, I have a recently funded center award, and that's why I wanted to talk a little bit about that. My project is the Ohio Valley River Corridor. It's a drug data research center, and this is in response to the Department of Justice looking at what are we going to do? We keep having an escalation with no end in sight. And so here just to show you over time what's gone on. I think this is very redundant to what Dan just talked about, but we see the age-adjusted death rate or even the crude death rate is escalating every year. I have data up through 2022. We see that it is starting to level off here. So every time we think something is leveling off, then we start to see new trends come out. So it's yet to be seen. Provisional data for 2023 has recently been dropped. However, I don't know how good those data are yet. So I've only gone up through 2022. So anyway, it seems that we are well aware for at least a decade that we've got a serious problem and that everything keeps escalating. There's money being pumped into the United States from various federal agencies to combat the drug overdose crisis, and nothing seems to work. And so the DOJ, their mission, they wanted to further the mission by providing resources to a university. They wanted to promote the collection, analysis, and research and dissemination of information to reduce fatal and non-fatal overdoses and promote public safety, support prevention, harm reduction, treatment, and recovery services. So the nice thing about the DOJ is they come at this from more of a multidisciplinary perspective. And what they're trying to do is to integrate data sets from a variety of resources to help inform public policy and treatment in particular. And I wanted to start off, I'm going to show you a little map here. This just shows you what has gone on in America. I go back to the year of 1999, and let me start it over here too. But anyways, it starts off, and you'll see a noticeable clustering of it. And this is what informed where we wanted to place our center. So we start off with a regional center that we're expanding, but this just informs where we started off at. Okay, here we see it's going over time, a dynamic map. And on the left, we have all opioid overdose death rates. And on the right, we have fentanyl alone. By the time we get to between 2014 and 2018, which is the third wave, they're redundant pretty much. So this map here only went up through 2020. But anyways, you can see that the right third of America has the highest rates of drug overdose deaths in America. Hold on, tonight. That one. Okay, and so just to show you that area that was a hot spot there, that's the Ohio Valley River Corridor. And one of the things I thought was very interesting is that, this is an old trade route that's at least 200 years old in America, where people would come through the East Coast, hop on the river, and go into America. And this seems to be the clustering of cases and a very unusual outbreak in rural areas. Not that we haven't seen that since the Civil War in America. Anyways, this was the clustering of the cases, and we thought the best place where we should create a regional drug data center. So these are the states that are involved in our center. We have Delaware, Illinois, Indiana, Maryland, Michigan, Ohio, Pennsylvania, Virginia, Washington, D.C., and West Virginia. There are also other states on the south side of the Ohio Valley River Corridor. However, they're picked up by states by the drug data center from the University of Alabama. That would include Kentucky in particular. That also forms part of the Ohio Valley River Corridor, Ohio River Valley Corridor. I say that in backwards. So in blue there is the US national average, and then the purple there is the Ohio Valley River Corridor average, and then you see the individual states with West Virginia at the highest. And since these data, this came out of 2021, since then it's even higher for West Virginia. And we're just looking how our states compare to other states and compared to the United States by drug. And so we see all drugs in red is Ohio River Valley Corridor, and in black we see the United States average, and we see very big differences in all drugs and opioids and stimulants. Benzodiazepines, not so much. And at this time, I don't have xylazine or other animal tranquilizers involved. One thing that is really important that we look at a variety of data sets, because we don't want to be overly focused on drug overdose deaths, because for every one fatal drug overdose death, we have somewhere between, I think, 6.4 and 7 point some non-fatal drug overdose death rates, but it doesn't speak to how many people are using substances. And this was a great example. If you look at the hottest spots here on drug overdose death rates the same year, we see narcotic arrest rates. They don't correspond one-to-one. So where people are using and what people are using is not necessarily the same cocktail in places that deaths are occurring. Anyway, so the
Hello,
purpose of,
Dr. Lori, can you
yeah,
please share your screen again so we can see your map? Thank you.
I'm sorry. I'm so sorry. Let me try again. So how much of that did you not see?
Maybe the last 4 or 5 slides.
Okay. All right, all right. All right, can you see that? Sorry about that. Again, here's my, this is Ohio Valley River Corridor. I was just showing you which was an old transportation route. This is where the river, how supplies moved through America. This was replaced by railway system. Then it was replaced later by the interstate. And again, it's a big transmission route. That certainly fuels the drug overdose epidemic. Here, again, let me show you the slides that I already briefly mentioned here. These are all the states, and these are the drug overdose rates in 2021. And the blue line there is the United States, and just how the region that we picked is mostly disproportionately higher than the United States. Here are the actual drug overdose death rates for all drugs, for benzo, stimulants, and opioids. And I have those broken out by state. And you see in the blue there is the United States, which is the average. And then you have the average for the Ohio Valley River Corridor data center. And here you can see them compare a simple picture here to going between 2018 and 2021. The red is the Ohio River Valley Corridor, and the black is USA average. We see that opioids are higher, all drugs are higher, stimulants are higher. The only thing that's not so different is there's only a slight escalation of benzodiazepines compared to other places in America. And then what I was talking about, this is our hot spots. This on the left here is a hot spot of drug overdose deaths for the year 2021. On the right is hot spots for narcotic violations or arrests per 100,000 populations. These are both rates, but you see that the hottest spots for drug arrests are different than the hottest spots for death rates. And again, that speaks to, there are a lot of people using substances that aren't dying from them. And so if we want to talk about the whole problem, we need to look at multi-sector data. These are just 2 sets. We intend to expand to include data on treatment, hospitalization, several public health data sets, and also criminal justice data sets as well. And they all speak to something different. Again, this is the purpose of our Ohio River Valley Corridor Drug Data Center. It's to support prevention, harm reduction, treatment, public safety, and recovery services. I think this is very interesting and innovative for the Department of Justice to fund this, because historically has not been very pro-treatment or using substances or other medications to help and assist people to abstain from using the more lethal forms of opioids. Our service area currently is in Delaware, Illinois, Indiana, Maryland, Michigan, Ohio, Pennsylvania, Virginia, Washington, D.C., and West Virginia. Jay Unick is my partner on this, who is in Maryland. And then we already were funded to expand our center. We will expand it to include the Northeastern United States and New England. So we have both New Jersey, New York, and England. And then our intent also is to expand beyond this one and move west and hopefully to include also Dan Ciccarone. And so we have two activities. We have the central data repository. We have dashboards. It's a very challenging one because nobody likes to share their data. We have a secret ghost server where we can look at a dashboard and see things better. But then everybody restricts about what's publicly available, which makes it difficult to do. And so one of the other ideas about why we need regional drug centers is because there are rules that apply to national data sets that don't apply to regional centers. So probably what we're looking to do is create a confederated data centers that are regional to be able to put together some data sets that aren't allowed from a federal perspective. Then we also have dissemination engagement. Data aren't useful unless we can help people to understand, or they can be put in a way or they're specific to their needs, and that is the part that Jay oversees. And that's all I have with that. And with that, now we are going to have Dr. Mason. Dr. Marianne Mason is an associate professor of emergency medicine, the associate director of the Buehler Center for Health Policy and Economics at Northwestern Feinberg School of Medicine. She leads the program for injury and violence research. She directs both the Illinois statewide unintentional drug overdose system and the violent death reporting system for the state of Illinois. And she has a long-term experience implementing public health surveillance systems related to drug overdose and violent death. Her recent work focuses on the escalation of drug overdose deaths among older adults as well as women. She identifies missed touch points and special needs of women and older adults. And with that, Dr. Mason, I'll let you take it away. And your slides went away, so you probably need to reattach them. Be better than me.
I'm doing my best to share my slides. Thank you, Lori. And actually, thank you, Dan, too, for setting the table for my contribution here. Let me see if I got this working. Okay, so are you seeing a glorious picture of our Feinberg School of Medicine?
Yes.
So I'd like to share this picture so people get an idea of where we're coming from with our research. So yes, I want to talk about women, opioids, and the real need for gender-specific harm mitigation strategies. I know that both Dan and Lori have focused on polysubstance issues that are emergent, but I'm going to focus specifically on opioids in this presentation, and I'll tell you why in a little bit. Globally, 60 million people used non-medical opioids in 2021, which is the latest available data. It's not the drug that is the illicit drug that is most used, that is cannabis, but it is the drug with the most lethal outcome. So I think Dan was pointing out earlier that, you know, having xylazine in the drug supply mix has certain consequences, but the more lethal substance is the opioid, the fentanyl, and that is just true in general. So there are going to be more deaths, more negative outcomes related to opioid use, even though it's not as commonly used as cannabis. So opioids can be divided into two kinds of categories. Opiates, which are naturally occurring, more like heroin, they're crops, they're grown, and then pharmaceuticals, which are chemically manufactured. So it's important to notice that difference in terms of gender, because if you look at this slide, you'll see that overall, about half of opioids used were opiates, so like a heroin, but that if you look at the split between opiate use and pharmaceutical opioid use by gender, you'll see that women are probably less likely to use opiate like heroin and more likely to use the more powerful pharmaceutical version of opioids. So that's an important thing to note in terms of how women are affected by this. Okay. Again, opioids are the leading cause of death for fatal drug overdoses, considering all illicit drugs. They're also a leading cause for people seeking treatment for substance use disorder, although worldwide cannabis is a contender there. And opioids are associated with injected drug use, which brings additional harms. One of which are infectious diseases like HIV and hepatitis C. But I just want to point out that even within this subcategory of opioid use, women face different and more substantial risks. So for women who inject drugs, they have a higher rate or a higher risk for HIV infection compared to men who inject drugs. So the risk profile for women is different, and it is more at risk for them. Use is more at risk. So I want to talk about some things that I don't feel are discussed enough and out enough in the knowledge base. And one is that there are social and biological differences between men and women in terms of how they access and use opioids. So women are more likely to misuse prescription drugs or prescription opioids than men. We saw that in the earlier slide. And then there are some reasons for this. One is the biology of women and pain. So women experience more acute and chronic pain than men. And so as a result, they're more often prescribed opioids than men. And the onset of pain relief for women who take opioids is somewhat delayed compared to that of men. So they can take more opioids before feeling relief, and that can result in the development of dependence faster. So there's this kind of pathway for misuse, sort of biologically, for women. While men have, they're more likely to use all types of illicit drugs and have emergency department visits than women. But when women are using illicit drugs, they're just as likely as men to develop a substance use disorder. And so, as I mentioned before, because of the biology of this, women can develop opioid dependency faster than men. But there's also actually some evidence that women may be more vulnerable to cravings and relapse than men, which has some implications for treatment in terms of overcoming misuse or dependence. So those are special considerations. Another special consideration is that distress is a risk factor for illicit opioid use for women, but not for men, meaning that there are some things that go along with opioid use for women that would need to be addressed to effectively treat and recover from it. So what happens is women experience more abuse, like sexual, interpersonal, emotional abuse, and that is associated with their substance use. So women in treatment for opioid dependency, they're reporting high rates of having experienced sexual abuse, traumatic childhood experiences, and sexual violence and harassment, especially in drug use environments compared to men. So they bring with them these, what I would call extra baggage in terms of their substance use and need for recovery compared to men. Another thing we probably are aware of, but isn't routinely talked about in my circles, is that while substance use is stigmatized for all persons, women have an especially harsh experience with stigma for drug use. And a lot of that has to do with the role they play in their families and their caregiving role and the role they play in society. So women who actually seek treatment for drug use often are treated hostilely or isolated. Their family is intolerant. They may be stopped from getting help because it would mean that they were publicly admitting having a problem, which in their society, their context would be problematic. But a really big driver of this actually is women's role as child caretaker in families and communities. They face an extra burden because women who use opioids while pregnant or parenting have often lost custody of their children to the state when children are born with opioids in their system. So they face extra criminalization and stigma, whereas fathers generally suffer fewer consequences. And that creates deterrence and barriers for help seeking for women in substance use disorder treatment, because it means that they're taking a big risk. They're putting their family's life and their children's life at risk because they could be removed into foster care or lose their family living situation. And so women have an extra burden in terms of approaching treatment and recovery. So I know this is it's kind of a little bit of a downer, but there's some bright side to this, and that is we do have very effective treatment for opioid dependency. Medication for opioid use disorder is effective. Buprenorphine and methadone are two of the most well-known medications for this. So we do have a kind of light at the end of the tunnel for people who are in position where that may be helpful. But some things about women going into treatment. First of all, there's increasing demand for treatment by women, which is a really good sign. But in general, women enter treatment far less often than men. So there's some considerations, though. Women coming into treatment look a little different than men. For one thing, they probably have been using opioids for shorter periods of time than men. So it gives them a little different profile. And as I was talking about before, women who are entering treatment bring some co-occurring illnesses that need to be addressed. So they have a higher level of care profile. They have more severe mental health, behavioral medical problems than men entering treatment. And as I mentioned before in the biology of this, they often have more severe cravings and while in treatment and recovery, which may in fact make them at risk for relapse at higher rates than men. So that profile gives us some special considerations for treatment for women. However, even if treatment is available, women experience particular burdens to that treatment, mostly related to their roles as mothers. So the barriers are, there's some universal barriers for men and women. The availability of enough treatment slots to meet the demand. Dan was talking about, these numbers are enormous, and worldwide they're even greater. I think 60 million was the number I saw. There's a great deal of stigma in drug use, and so entering treatment requires one to address that. And there's what I see more and more is people coming out of treatment, but they're coming into communities that lack support for them, long-term support. But women carry an extra burden here because their family role as caretaker. They're more likely to live in poverty and have financial dependence. They face transportation issues, safety of transportation. They can't access affordable childcare, and a real big issue is the threat of the loss of children to the state. So all of these are the extra burden women carry with them in order to get to treatment. So what does this mean? What do we do? It means we need to weave in gender considerations into all efforts to mitigate the harms of opioid use, right? It means we have to think creatively and consider the perspective, the lived experience of women in need. I'll just give you an example here. In the US, around 2014, they released opioid prescribing guidelines. And the intent was good, right? We wanted to stop the overprescription of opioids. So it put in place, unfortunately, without viable alternatives for pain relief, but it put in place guidelines that actually restricted the opioid prescription. So if you do something like that and you aren't considering the experiences of women who are prescribed more opioids, who experience pain at higher rates, and who develop dependency after shorter use periods than men, the outcomes are likely to disproportionately impact women, right? So what would a more gender responsive approach look like? It probably would have, should have, could have involved women in the development of policies to mitigate that. So most likely a better approach would have been to have robust alternative treatment strategies on board at the time that happened that can address the needs of women and the pain they suffer. So I just list them out here. But without thinking that through and without understanding the differences that women experience in opioid use, women end up disproportionately punished by what was a well-intentioned policy. And so that just illustrates the importance of how we have to consider women in all this. Another kind of bright spot here is the development of women-only treatment centers. They've emerged actually all over the world. This picture on the lower left here is from East Africa, where I'll note that the predominant area of treatment is methamphetamine for women, but this is a women's only treatment center. This one in the upper right is from Iran, and that treatment center includes opioids, and methamphetamine. And then this other picture is actually from Minnesota. They're very common in the US, but they're evolving around the world. So what these can do is they can help reduce stigma for women, and they can actually more tailor to the unique needs of women who use substances. One of the things they can do is create the higher levels of care necessary to address the things women are bringing to their treatment needs. And they can offer a safer environment. Women experience sexual abuse both in drug use environments, but also in communities of recovery. So this can create a safer environment for women. So what are some ways we could think about a gendered approach to treatment to benefit women? One is including family support stipends for women who are caregivers who enter treatment, and that could enable them to save their housing until they're out and earning. Treatment centers could be supportive of parenting and actually co-house a child or children in the treatment center. They could offer models of progressive engagement, especially for women who are pregnant or parenting, who have very good reasons to avoid seeking help. If we can offer low barrier harm reduction, there's a better chance of engagement there. And then the idea of wrapping services around to people to help meet their family needs so women can get the treatment they need is a very important one. And then again, because of the special challenges women face in recovery, just offering more in the community to help support their role. So I think by doing this, by putting this presentation together, I really want to stress that, women are a significant part of the current drug epidemic, and they suffer from misuse in unique ways. There's biological processes, there's social processes, there's psychological processes at play here. But that there are some ways that are evolving to address this in policy and in our response to this, and we probably need to grow and support them. And I just want to say, by doing this, we also have the opportunity to improve the lives of children who are attached to the women who are seeking help. So thank you, and I guess I'll turn it over to Jay.
Great. Thank you so much, Dr. Mason. Next up, we have Dr. Jay Unick. Dr. Unick is a professor of the School of Social Work at the University of Maryland and a behavioral health services researcher with extensive experience evaluating community behavioral health programs with a particular focus on the epidemiology of the opiate epidemic and acute behavioral health care. Much of his work is focused on changes in the heroin and opiate supply and the health consequences of those heroin market changes. More recently, he's focused on understanding how to use existing data sources to evaluate opiate-related services. His work on opiates relies on large medical claims data sets, epidemiological morbidity data, and drug supply and pricing data to understand how the opioid epidemics has changed for the last 2 decades and how changes in heroin market conditions predict different health consequences. The recent increase in the fentanyl-related overdose deaths is an example of how the supply of drugs affects the health injection drug users. With that, I will turn over to Dr. Unick. Thank you.
Well, thank you, Lori. Sarah, do you want to get those slides up? Thank you. I need better pictures for my slides, that's clear. So I'm here to talk about recovery systems, and Marianne really did a really good job introducing some of the important features of opiate use that is positive, which is we have effective medications to treat opiate use disorder and to treat the issues that come with opiate use disorder. We have a number of medications, buprenorphine, methadone, and Vivitrol are used in the United States. Other countries have approved other medications to treat opiate use disorder. And so there are some positives, but in order to make those work, we need to recognize that these are not just medical problems, these are social problems, and they're embedded in the full social matrix. Certainly gender is one of the relevant considerations. Thank you. So it's not difficult to understand the idea that substance use is a social problem. Substance use risk is linked to a variety of factors: trauma, family history, high-risk environments, as well as personal and genetic risk all play a role in sort of orienting an individual into a higher or lower risk of developing a substance use problem. And so the same individual can have a lot of risk in one environment, but low risk in the other environment. And a lot of that's based on, is the person in a supportive environment? Does the person have opportunities to meaningfully engage with their community? Is the person respected? Is the person under threat of violence? These are all things that affect and interact with the personal and genetic risks. And in addition, we have these larger social issues that are at play as well, which are stigma and treatment systems and how stigma and treatment systems interact. So if the systems that would be providing medications for treatment or psychosocial treatments are not available to individuals, are not available to women, are under threat because women are concerned about their children being taken from them. There's a whole host of forms of risk that are related to stigma. And so if society can't recognize the sort of the human and social aspect of it, it's hard to develop effective treatment systems to address these. And what I really want to focus on in this talk is some of the features of a treatment system that can make the medications more effective by providing a set of support structures that allow individuals to move from high-risk environments to lower-risk environments in terms of their substance use. Next slide, please. But I want to start with one of my favorite studies in this area of substance use. So a lot of what we know about the biology and the physiology of addiction come from rat studies. And you can see the rats living in their cages here. These are very deprived rats. They live in a very poor rat environment, and they're isolated from their rat peers. They don't have a lot of rat supports. And so when we provide them with drugs, they take them because they are deprived of anything else that would bring joy or pleasure to a rat. And so there's nothing for the rat, there's nothing to compete with the risk of drugs. And a lot of the sort of the drugs produce poor outcomes studies that drugs drive the addiction come from these kinds of environments, which is not consistent with how any of us, I hope, live our lives. The idea that we would live incarcerated in a small little cage is not a particularly appealing idea for any of us. If you move to the next slide, please. So one of the things some researchers did early on is they tested this hypothesis. And it's called the Rat Park study, and you can look it up. There's a bunch of stuff on it. But what they found is that environment matters tremendously, and that rats, given the option of socially engaging with other rats by doing, rat fun things, running in little cages and walking through boxes, as the cartoon suggests, that rats were not just slaves to the drug. They didn't just use opiates. They didn't just use the drugs available. They were really interested in having a healthy lifestyle. And so I think one of the things that's really important when we think about what it means to recover from substance use is one of the things we have to do, and this is a systemic and social issue, is replace environments that are high risk with environments that are lower risk. And that's not something that we're particularly adept at. Providing medications, we're pretty good at that. So some of the reason we're in this problem is because of the over-availability of medications. But providing medications is an important piece, but it is not the only thing that has to happen. Next slide, please. So as I've mentioned before, we really do have effective medications. There's a tremendous amount of evidence. You can look at the summaries of evidence in places like the Cochrane collaboration. They provide a tremendous amount of empirical support for methadone, buprenorphine, naltrexone, other drugs. Some other places have approved a wide variety of opiate substitution medications, and we know those work. Individuals that stay on those medications have better outcomes. They don't engage in consuming drugs purchased off the street. They have better employment outcomes. They have better social outcomes. They have better family outcomes. All of the things that we want to work and build on with our treatment system happen when we can get people onto medications. So that's a lot of the access issues that Marianne was talking about, but also stay on medications long term. And that requires support. Next slide, please. In the United States, the uptake of medications to treat opiate use disorder are really poorly utilized. About 7.5% of individuals with a substance use disorder receive substance use treatment. So we have a large problem, as demonstrated before, but we have some treatment availability, but people aren't using treatment when it's available. And then even fewer people sustain recovery for the long term. Now, that doesn't mean that our treatment of chronic diseases, particularly opioid use disorder, but other chronic diseases is bad. It's just that it takes a sustained effort. It's not a one-time thing. It takes a continuous effort to build support. Next slide. When we talk about recovery, and when I talk about support, I mean this along a series of dimensions. And so I want to just sort of outline when I say recovery, what exactly am I talking about? So four overarching domains that we want to seek support in. One is health. So we want to help people manage one's symptoms. That's in the context of opiate use disorder, that might mean abstaining from opiate use. That might mean reducing opiate use in a harm reduction framework. All of those can be achieved through the use of medications such as buprenorphine or other harm reduction techniques. So we want to reduce the harm associated with either substance use or help individuals abstain from substances that they would purchase off the streets or acquire through other mechanisms other than through a prescriber. So that's what we've talked a lot about in this presentation so far is those forms of medication, getting people into treatment. But if people don't have a safe place or a stable place to live, if they're not free from domestic violence, if they're not free from other forms of violence and threats, it's hard to sustain your recovery. In the United States, we have a number of people that are homeless, and that homelessness produces a real barrier to treatment uptake because individuals have a hard time engaging in, they have a hard time storing their medications. They have a hard time feeling safe in their environment. And so drugs represent an alternative to that. And so if we are going to improve outcomes, increase medications, we have to provide safe and stable housing for individuals. Individuals have to have some purpose for their life. I think most of us need some form of engagement, and that can be family activities, that can be employment, that can be school, right? So all of these kinds of sustained living activities have to be supported in some form of recovery. For individuals that have had serious substance use issues, often these things are at risk. They have had difficulty with employment, and there is an employment history that presents a problem for them for getting subsequent jobs. They might have had some disruption of their family life, either because of their substance use or the thing that caused their substance use. Obviously, there's a variety of different forms of issues that come up when people have been using substances for a long time. Being able to support individuals moving from a life that has a tremendous amount of risk to a life that doesn't involves providing some measure of purpose and support for individuals in order to gain employment, get back into school. And there's a number of barriers that we have to address through our recovery systems in order to achieve that. And then finally, we all need meaningful relationships for our lives. This gets me back to the rat study, where the rat park provided an opportunity for rats to engage in social activities that they found meaningful, and those represented an alternative to substance use. If we deprive people of opportunities to have meaningful engagement, or if all of their meaningful social engagement comes through the use of substances, then we're going to have a hard time having people engage in recovery and continue with medications, because we have to provide some form of social support. So when we think about building recovery-oriented systems of care, we have to think along these four dimensions. We have to provide a mechanism for individuals to support their health. We have to provide safe and stable housing for them, a place to shelter. We have to provide some form of support for purposeful or meaningful activities. And then we have to provide a meaningful community that can support them in reducing harm or promoting recovery or abstinence from substances. Next slide, please. So just diving into each of these, I want to think about various ways that we can build treatment systems that support recovery. So in health, we can think about peer treatment navigators as an important mechanism for getting people onto and supporting them in symptom reduction, either through harm reduction activities or through forms of medication, adherence, uptake and adherence. Recovery housing represents an opportunity to get people into a stable housing environment, to build some recovery time that can then allow them to be linked to supportive housing or other housing options that will provide a stable long-term solution to housing needs. We have a variety of different forms of supporting people in developing engagement in community activities in the form of recovery high schools for young people, or recovery-oriented colleges, recovery-friendly workplaces, and in supported employment opportunities that help individuals. We also have to deal with some of the consequences of long-term substance use in the form of legal involvement. So sometimes we need to support people in addressing outstanding warrants or other criminal justice involved activities that are barriers to uptake and getting employment. And then there's a variety of different ways that we can provide support to individuals through recovery support communities or other activities like Alcoholics Anonymous or Narcotics Anonymous that provide communities that can support individuals in recovery. Next slide, please. So peer recovery support services are an emerging area in the United States to build a mechanism for getting people that are actively using and at some level of risk into various forms of treatment services. And that can be anything from harm reduction all the way to enrolling in outpatient clinics or inpatient clinics for sustained treatment and access to medication. So for example, I'm sitting right outside our hospital here. We have peer treatment navigators that are in the hospital so that if somebody comes in with an opiate overdose, during the process of recovering from that opiate overdose, a peer, somebody that has lived experience with substance use, that comes from similar neighborhoods to the people that come into this hospital, that looks like people that come into this hospital, that have backgrounds that are similar to people that would come into this hospital with an opiate overdose, can have a conversation with them and work with them on moving from use to some other level. And then we use a lot of motivational interviewing and other evidence-based approaches as part of our peer recovery service program to help move individuals into a better state of health. And again, that represents, there's a range of options for how we can do that and what that would look like using motivational interviewing and stages of change model where we ask people where they are in terms of their contemplation or how willing they are to engage in various forms of treatment. And then we try to move them along that continuum to a set of practices and behaviors that lower their risk and improve their health. But the idea of peers is to engage, have people that actively understand what the life and the lived experience of these individuals are, and they can represent a more credible bridge relative to somebody that comes in that has an advanced clinical degree that might not have had the same background as the individuals that are struggling with the substances at the moment of time. So we really use them to engage individuals outside of traditional clinical models. We can do it in either hospital settings. We can also do it in community settings. We can do it in outreach settings. There's a variety of ways that peers can be involved in linking individuals to treatment systems to help them either get on medications or address other forms of harm. That could be linking them to needle exchanges and other forms of harm reduction as well. So I think through all of this, it's really the idea of a credible source of information and somebody that can relate to the person that's struggling with substances. Next slide, please. Once we get individuals into treatment, we need to provide a stable place for them to live, a place that can support their recovery. Early on in recovery, that's probably going to be something like a recovery housing or recovery residence, where these are non-medical settings. These are residential facilities that allow individuals to recover from substances. And they do so by providing a stable, supportive environment. You would have, you'd have a clean house to live in. And then they also might link individuals to other forms of services. There's various ways in which these are structured. They can be structured as a very intensive program with on-site services, or they might just be a residence where people that are all in recovery and going to some form of treatment outside of the residence can live for a period of time. These are usually short-term, usually 1 month to 90 days. And they should have, as part of that, linkages to longer term stable housing that can be in the form of supported housing, which is a way in which you can provide some form of ongoing support to individuals, or it might just be rental assistance or other forms of financial assistance to help people get on their feet following a prolonged period of substance use. Next slide, please. So one of the important pieces of getting people through the recovery, and once that initial stage of recovery has been completed and individuals are stable on medications, having them re-engage with the world either through school or employment or other activities. It could be creative activities or other things as well. But traditionally in the United States, we really think about supported employment and helping individuals get back into in some form of engaged employment. And generally, these are in the form of case management programs or other supports that help people address barriers to employment. And those barriers could be job training. So we can, help somebody learn to become an apprentice for an electrician, or help somebody to gain some particular skill that allow them to be employed. Addressing issues around transportation or lack of childcare, particularly for women. having children at home is a real barrier to engaging in employment markets. And so childcare is expensive in the United States. So providing support for individuals around childcare can really help facilitate entrance into the labor market. And some individuals are still engaged in some form of substance use. And so addressing that in the context of employment or addressing criminal histories are really important. For a lot of people, their engagement with criminal justice and law enforcement through the course of their life using substances can produce barriers. So you can have outstanding warrants that show up in a job interview. And so a lot of these warrants are for things that aren't really they're more nuisance and barriers to employment rather than things that we really want to spend time prosecuting. We can work with prosecutors, we can work with local criminal justice officials to eliminate and cleanse the record so that individuals can engage with employment. And there's a number of initiatives to do just that, where we work with local law enforcement, with local district attorneys to clear somebody's record so that that doesn't become a barrier to employment. So it's a mix of things from supporting individuals in getting the skills necessary to engage in employment, maybe reacquiring some skills or reacquiring certifications for things that might have been lost during the course of substance use, or addressing other forms of barriers such as childcare, transportation, and criminal justice histories. So it's a full package of services that work with individuals through this early support and recovery phase to get them re-engaged in life in ways that allow them to be both financially supportive of themselves in the future or their families, but also to engage in meaningful activities. Next slide, please. And finally, as individuals move through these trajectories in life, having places they can go to process and communicate and talk and work on issues of recovery where they can access various forms of services, so they could access job trainings or other things, or maybe provide child care or transportation options, are recovery community centers. In the United States, there's a variety of different models here. Some of the models are very volunteer run, so that would be Alcoholics Anonymous or Narcotics Anonymous, that are support groups, all the way up to formal recovery centers that really provide a full suite of services for individuals, not only sort of access to things like supportive employment, but also opportunities to engage in reading groups or meet with friends, or a place where you can just go and talk to somebody or engage in social activities. The community center might organize trips to places. So for individuals that have spent a number of years engaged in substance use, a lot of their social network was around substance use. And so if you are going to exit a world in which substances are the primary mode of social interaction, you really have to develop a new set of social connections and a new social network. And often for individuals, this is the most challenging part. You know, we think of substance use in very negative terms, but for a lot of people, this is the supportive environment that they had. These are the people that nurtured and cared for them. And there might have been struggles there and related to substances, but for a lot of these people, this was what they had in terms of social support. And so exiting that world in which you have some supportive network to a world in which you're isolated and alone it gets us back to that Rack Park story. That's a difficult place to move through in your recovery journey. So in order to help and facilitate that, we need to provide substitute environments where individuals can rebuild social networks, reconnect with other people, whether that's family or friends or new social connections that are built around this idea of recovery. And last slide, please. So the positive message is that we have effective medications that can help people control and manage their cravings for opiates. We're developing some drugs for other substances as well. There's some encouraging news on the pharmacological front, but we are not going to pill our way out of this. It is not going to be a medication-based solution. We know that to be the case. We need to provide systems of recovery and support to help move individuals along their recovery journey. And we're going to have to do that by linking individuals to these recovery-oriented systems that can address some of these social and personal factors that get in the way of individuals' recovery journey. That's going to include changing payment systems. That's going to include addressing substance use-related stigma and building more interactive and comprehensive support systems to support individuals on their recovery journey.
Thank you so much. Goodness, we've had such outstanding speakers today, and we aren't finished. I want to note that we are having this panel during the United Nations Commission on the Status of Women. It is mostly virtual. There'll be some on person in New York, but this is session 68. And the two themes are poverty and social protections. And absolutely, there's an intersection between drug use and treatment and the themes of the Commission on the Status of Women. It's the largest convention of women in the world. And so your presentations have been actually available all over the globe. And we have one more speaker. One run, the Women's UN Report Network always likes to have a grassroots dimension in the subject matter that we address. And today we have with us Alexander Herman. Alex is going to tell us about the crisis impact of drugs in the family and what he's studying in order to eventually become a professional like maybe all the rest of you. Okay, Alex, please.
Yeah, I appreciate the introduction, and you can definitely look at me as a sort of case study of what you guys are all talking about, a sort of boots on the ground perspective of what you guys are all working on. And I just want to say I appreciate for the opportunity to speak with all of you great people, and I hope that we can all reach some of the same conclusions. But the main objective of my talk today is obviously to talk about my personal catalyst, that being, a person that was subject to a substance abuse disorder with my brother. And at the age of 19, we found out that he had overdosed at the age of 24 due to a fentanyl analog through an illicit drug source. There wasn't an actual naming of the drug that was being distributed, but since my brother was in the drug market trade, he was selling in order to increase his wealth and to increase his societal reputations, that whatever that may be. He did fall, unfortunately, susceptible to that fentanyl crisis. And so with that, it started with me obviously realizing drug use has an impact on people's lives. Drug use has implications through families, through societies, through policies, through countries, et cetera. It's a very breadcrumb trail topic, which is mainly what got me interested in studying drugs of abuse when I came to the University of Minnesota, where I was studying psychology and neuroscience, and I wanted to understand the biological mechanisms of addiction. That being said, there are ways that we can explore drug use that aren't, traditionally accepted. That being that drugs are, use of choice. People have a right to use drugs. Everybody has their own reason for using drugs, even if they have potential consequences. And that comes with different theories of why addiction comes in the first place. One of those theories comes from an actual faculty member of the UMM that studies drug and addiction, named Monica Luciana. I plan on working under her as an internship for drugs and abuse studies. But mainly the two prevailing theories are obviously positive reinforcement, adding things that increase the pleasure, the do it again, the dopamine signaling pathway. Everything is primarily conditioned with that initial step. And the other prevailing theory is negative reinforcement. We're using these drugs to prevent these negative feelings to occur, mainly by alleviating the existing, aversive states in order to increase the probability of you feeling good again, which unfortunately increases the probability of you using and can also increase things like addiction, withdrawal, tolerance, and different conditions. But that being said, what I see and what other studies see is this sort of like hedonic, like homeostat. We're trying to maintain balance in our lives. And one thing that I noticed that I really enjoyed that Dr. Unick was prescribing was that there's a sociological impact. There's a reinforcement of everything that's environmental all the way down to our genes. So from the seconds to minutes to months to years before we do make the decision to either smoke our first cigarette or drink, our first cup of coffee, there's a susceptibility for us to experience these pleasant, hedonic-like feelings. And some people are susceptible. There's a cycle of addiction. There's different, comorbidity factors that go along with that. But ultimately, we're dealing with a multidimensional issue, which is what I've sort of uncovered through reading through literature, reading through studies that mainly deal with addiction. So after going through the explorations of drug use, there's this point where we reach where is the therapeutic potential, where is the therapeutic window that we talk about in pharmacology for these drugs. Each drug has a limit to what they can do for the individual up until they start to have negative effects. And so what we see is that a lot of people either are taking drugs for interpersonal development. Let's say they want to be, they want to intellectually develop their skills by taking, LSD, or they want to have a certain interpersonal experience, whether it be exploring novelty or falling susceptible to peer pressure systems. And then there's also the sociological component. There is, peer pressure, there's values, there's morals. Of course, this varies between Western and Eastern communities, given that they all have different drugs trends. For alcohol, for instance, is very large in the Western civilizations. But in terms of understanding addiction, what I like about all of these different, recovery-oriented systems, especially for opiates, and also talking about like the gender specific strategies in order to understand opioid focus, is like there is this sort of what we call neuroeconomic value in terms of what happens when we take drugs. What happens over the course of populations is that we shrink our perception of value to the point where we think that this drug is the main source of our value of our time. It needs to be, focused on obtaining these drugs. And given that the environment that we're in, there's a lot of ways to become susceptible to, our phones or to actual illicit drug markets. And what happened, unfortunately, with my brother is that he got caught up in these sort of complex structures and may not have had, a strong support system. He could have picked the wrong friends. He could have grabbed the wrong bag in order to deal and distribute these things. He could have been in the wrong environment. And that eventually led to him making the decision. But ultimately, what I want to believe, obviously, because he was a very close family member, he's my only blood related brother, and him being gone arose a lot of questions like, why would he take these pills? Why would there be a situation where he felt like he needed to even try or to experiment with these drugs? And the main question is was he in a state where he could, morally make the right decisions? Was he trying to figure out, economically speaking, like, if I want to continue on living this life, do I need to take these drugs? He was very fond of smoking marijuana to reduce stress. He drank alcohol with his peers to express himself and to reduce, the stresses of him, living in his life, because he obviously struggled a lot when he was a kid. So that being said, it kind of brings us to this idea of drug use being like impactful in society. These implications for opioid abuse extend far beyond any one person's perspective. It's a very holistic human rights issue. And, looking at ways that we can target these susceptible populations and implement different strategies, whether it be like Dr. Unick said, health, home, purpose, or community. I think all of those four pillars have a large facet in the dimensions of recovery. And I really enjoyed the fact that you mentioned peer recovery support services, because I'm actually training in harm reduction services, and making those concepts available to people who are dealing with drugs of abuse, given that I have such, expertise, if you want to say, in dealing and communicating with these feelings of utilizing drugs, both from personal experience and obviously from academic experience. But just to kind of summarize this up, the future trends that I see are all similar with all of you. It's, the difference of the fentanyl analogs, the skyrocketing use of opioids and pills, and the use of these proxy wars, whether it be China distributing large amounts of fentanyl analogs to the US, using the cartel to distribute them to the United States and affect large portions of the population, given that we are at such a standoff between these two countries. I also kind of wanted to mention like cartel economics, like looking at how the cartel, in terms of like implementing large scale drug operations in order to meet the standards or meet the needs of the illicit drug trade, which is always going to exist, unfortunately. There's policies that you could spend an entire lecture talking about that go all the way back to the opium poppy stacks or whatever, that have to they have important implications, but unfortunately they get misused, or old things need to be updated. But lastly, I just wanted to make it clear that my my main attitude is that this is not only just like a societal problem, but it's also an interpersonal humanistic issue. And if the more I understand the neural mechanisms, the receptor subtypes, the morphological differences between brains that are addicted to substances, the more I realize that this could be um, something that a lot of people like don't understand, more or less. They need to have the proper, educative systems. They need to have the proper role models. They need to have proper peer recovery support services in order for them to understand the magnitude of this issue. So it doesn't just become like another failed DARE program of pushing off issues in order for them to come back tenfold. So I guess what I'm here to say is that my generation will hopefully understand the neural mechanisms of addiction so as to meet the means of an entire nation that are suffering from these opioid pills. But yeah, I mean, in terms of what I have to offer, it's simply just perspective. I'm still, young, very novel, and intrigued by the history of drug use and practices, especially with the illicit drug market trade. Um, and yeah, I hope the one thing that you guys can take from this is that these affect real families. These are real people. These are, very complex dynamics that affect your neighbors, your, people that you walk across the street could potentially be dealing with these issues that are definitely scrutinized. And that's something that we need to reduce, is the stigma, the societal attitudes towards drugs in the next generation. Yeah.
Thank you so much, Alex. The courage it takes to talk about the loss of people that were dear and near to us with these pills and all the forms of drugs. Thank you very much for integrating it also with your studies. Sarah, how are we on time?
We're down to a minute right now.
1
So
minute. Oh my. Well, if that's the case, there's a couple questions. Someone asked if drugs are related to prostitution. I think that's like another complex question, but sometimes pimps will cause a woman or girl to be addicted to the drugs in order to be a prostitute. The three largest illegal items in the world are arms, drugs, and people in trafficking. And now with our multiple wars and so many people who are refugees or migrants or displaced, the social support is even more challenging. Lori, do you want to say a few words?
yeah, I would just say this, that obviously sex trafficking, drugs are connected, deeply connected. We don't really find one without the other, and they're related to, I think it's bigger than a person, it's systems that we have to address in the trafficking of it. But I think the person want to know if anybody had looked specifically at Thailand, which we know is a major contributor of humans for sex trafficking. I personally haven't, although I've seen people try with indirect population estimation to estimate the size of that population. But I don't know about JR, Marianne, if any of you have looked at Thai sex trafficking.
It's everywhere.
Yeah.
I have not.
And
but
I lived,
it
in
is everywhere.
Italy, and I could see the
Yeah.
drugs passing, and they didn't know I spoke English and Italian. So I could hear what they were saying. You could have this territory, you have to bring in this much. Excuse me, that's a very tragic outcome. Yes, do you have something to say, Doctor? Do you have an additional comment for us, Miriam?
I just wanted to say it's interwoven into all women and drug use literature. And in some countries, it is more present than others. but I didn't find anything specific on the percent of women who use drugs who are also sex trafficked or sex workers.
I would just say I've run
Okay.
across I've run across this one time while I was at Yale University where there was a major sting on drug trafficking and bringing women through the health system. Our victims that are being trafficked, and substance use was part of the intervention. Anyways, so I think that's it. I think that we'll wrap up.
Yes, thank you all for really what was an enlightening, inspiring in the possibilities for addressing the drug issue. But we also hope to take this panel to the UN further and show the many dynamics that you have through education and science presented today, and also the human voice, as Alex had said, the human dimension of trafficking, of drugs is enormous at all ages and getting worse. So we will proceed and we'll try to do our best. And thank you so much to our distinguished speakers for sharing with us your knowledge that will help us address drugs and substances abuses, especially for women. Thank you.